Bismillahirrahmanirrahim. Assalamu alaikum. I welcome you to the 20th Shaukat Khanum Cancer Hospital Symposium. This is Cancer Care and COVID-19 session. My name is Dr. Rizwan Masood Sheikh. I'm a consultant medical oncologist in Shaukat Khanum Cancer Hospital. As you all remember, last year we had a same session, which was cancer care and COVID-19. And at that time, we were going through a second phase of COVID-19. So we discussed in that session how to prioritize our cancer patients during the first and second wave of pandemic, and how to reorganize our cancer services. Now we are going through the fourth phase, and what lessons we have learned so far, and how could we prepare ourselves, God forbid, if anything same happens in future. So this is the aim of this session, and I am absolutely delighted to have eminent speakers all around the world, and they are going to discuss different aspects of cancer care during the COVID-19 pandemic. Let me introduce to my first speaker. He is Professor Syed Hussain. He's a professor of medical oncology in University of Sheffield in UK. His special interests are management of urological cancers, clinical trials, early drug development, and translational medicine. So I welcome Professor Syed Hussain.
Assalamu alaikum. It's a great pleasure and honor for me to be in the Shaukat Khanum Annual Symposium. And inshallah, next year we'll be all joining together in a face-to-face meeting. Today, I've been asked to cover a very interesting and important topic looking at managing cancer care during COVID-19 pandemic and the impact it has made on cancer diagnosis and cancer treatments globally. We'll share some examples, and then I will talk through some of the data that we had from our own institute, from my patients, in terms of the first lockdown and the outcome of patients who were treated with systemic therapies during that phase as well. Many of you have met me before. I'm Syed Hussain. I'm a professor of medical oncology and consultant at University of Sheffield and Sheffield Teaching Hospitals in Western Park Cancer Center. These are my disclosures. As I was saying, COVID-19 has brought huge challenges. And at the same time, there are huge opportunities as well, because we are starting to learn how to manage patients during this COVID-19 phase as well, because COVID-19 has been there with us for the last 18 months now. And it seems to be becoming a part and parcel of our lives now, because things, we do see increase in the cases. And then I think it's important for us as a medical fraternity to start thinking about how best to manage these patients. And especially when we talk about cancers as well, we need to be very carefully looking at the impact that COVID-19 can have on cancer diagnosis and cancer treatments. So this is important to understand. And again, this is a slide courtesy of my colleague, Jim Cato, how this all started, giving a historical background of that. 31st December 2019, there were 27 cases of pneumonia with unknown etiology reported in Wuhan. And then in January 2022, first case was found outside China in Thailand. So if you look at that history, it's interesting to see how things changed and how it came to other parts of the world, including initially in Thailand in January. And then first confirmed case in Europe was on 25th of January in France. And then UK nationals were repatriated from Wuhan in January 2020 on 31st of January. And then 1st of March, there were 35 UK cases in total. And then 5th of March, CMO of England announced first UK death. And then WHO declared COVID-19 as a pandemic. So it has been ongoing for quite a long period of time. And, we are starting to learn how to deal with it in the best possible way. In terms of the impact that COVID-19 had, is very interesting and important to look at. that this is a manuscript from European Urology Focus, and what it very clearly showed was a significant drop in activity in Italy, for example, in terms of the beds available and the overall surgeries that were being done in Italy as well. Similarly, this was a paper from May 27, 2021, looking at drop in activity in India, for example, looking at the major surgeries and minor surgeries, percentage reduction between March to May 2019 to March to May 2020. This is a significant decline in terms of major surgeries, minor surgeries, outpatient chemotherapy, patients undergoing radiotherapy. So there's a significant decline in all these treatments. So there is a significant drop in activity that we are seeing with COVID-19 and outcomes. In terms of UK colon cancer, if we look at as well, looking at basically looking at treatment referrals and looking at two-week wait referrals, there was a significant decline again between sort of looking at March 2020, April 2020, and May 2020. If you start to look at percent reduction, was 63% in April 2020 and in 52% in May 2020. So this was the first lockdown that we are seeing. So in UK colon cancer, there's a significant drop in activity and in treatment referrals as well, significant decline in treatment referrals as well. So those are important figures because that helps you to manage the outbreaks in future. And that is where the opportunities are, that we need to really learn and understand how we can deal with these pandemics better, and even how can we manage these pandemics while they stay with us in this sort of a setting. Risk from surgery with COVID-19 as well is important to understand in terms of elective surgery. And if you look at the sort of risk factors, 30-day mortality increases in emergency surgery and in terms of age greater than 70 years, but even in age less than 70 years, there is a significant increase in 30-day mortality when you look at patients with COVID. So that is important to understand. This is from Lancet, July 2020, and looking at those number of patients with mortality and pulmonary complications undergoing surgery. These are impact of delays on survival. And again, these are important facts and figures because that tells you that delays which happens in terms of their diagnosis and delays that happens in terms of treatments can have significant impact. And I think there was a time in early COVID-19 pandemic where the sea of COVID-19 almost took over the sea of cancer. And there was a concern that any patient who's coming near a hospital will get COVID. And I think we needed to understand that there's a hypothetical risk that you will get COVID, but cancer is definitely a reality. And again, that you can see that the decline in sort of number of patients, impact of delays on survival is seen, for example, in bladder cancer and kidney cancer, significant impact in terms of poorer outcome if there are delays in cancer diagnosis and survival. And we are seeing more of the stage migration nowadays. We are seeing more higher advanced stage cancers presenting to us because these patients have been sitting on symptoms and concerned about that if they go near a hospital, they might get COVID. So those are sort of things that as a medical community, we have to really highlight. The fight we had in terms of early diagnosis of cancer, for which we worked over the last 20-25 years, we don't want to go to basically waste all that work that was done in trying to move diagnosis of cancer to an earlier stage and improvement in cancer treatments as well. We really need to work on it to make sure that in any pandemic or any future events as well, we are ready for that, and we are not delaying the diagnosis and not delaying the treatment pathways for our patients. Because you can see, for example, in bladder and kidney cancer, in brain tumors, in colorectal, there is a lot of reds you can see, which are high sort of detrimental effect of delays in terms of on survival. I think we need to understand that we learned a lot with the changing priorities and strategies. Wave one, there was a case selection high priority cases, defer non-urgent cases, consider non-surgical treatment where possible, and avoidance of surgery until COVID-19 improves. Wave 2, we build up of deferred lower risk cases. So there was already a buildup of cases. Temporizing measures were running out of time. More advanced disease become apparent, and surgery, despite COVID-19, was being used in wave 2. And come wave 3, and we then had vaccination and variants that were coming through. Better risk knowledge was present at that time, and buildup of community workload and learning to manage surgery and COVID-19. So those were different ways of dealing with these cancer cases during that period. Case selection was important, looking at low priority cases, intermediate priority, high priority, and emergency. Those were different ways of case selections. This is a paper from Christian Stensland and my colleague Jim Cato, David Keynes, and other colleagues around who suggested triage of surgical cases during the COVID-19 pandemic. So quite an interesting paper that started to look at how we can look at prioritizing and see if there will be a clinical harm if the treatment is delayed. So low priority was that clinical harm is very unlikely if postponed for 6 months, but life-threatening is where life-threatening situation, or high priority cases where clinical harm very likely if postponed for greater than 6 weeks. And again, those were sort of things that were looking at bladder cancer as well. If we take it as an example, for example, offering cystectomy for muscle invasive bladder cancer, considering neoadjuvant chemotherapy, or in terms of high priority where clinical harm or progression in terms of metastasis, anemia-related complications, and cancer-related deaths very likely if postponed greater than 6 weeks. So those were sort of cases like T3, T4, muscle-invasive bladder cancer, and moving straight to cystectomy at times in the first wave, although later on neoadjuvant chemotherapy was being used quite routinely as well. In terms of wave 2 and 3, understanding, reducing the healthcare interactions with single visits, fewer consultations, virtual tumor boards, e-consultations, telemonitoring with early discharge, hospital at home, telemedicine using counseling, treatment choices, follow-up, surveillance, survivorship. So there were different things that we learned, and we actually adapted to the changing times here, and delivery of care with SARS-CoV-2, decisions in care, and adaptation of services. So it was very much done in partnership with other healthcare organizations to try and make sure that we can deliver the treatment safely, and we can deliver the treatment what is important as soon as possible. Again, treatment selection was based on reevaluation of risks, increasing use of surveillance, and then efficiency of care was looking at, for example, hyperfractionations, long-acting drugs, reductions in intensity. So there were different ways of using that information and knowledge. How to manage muscle-invasive bladder cancer. Again, in those sort of settings, there were questions that surgery or radiotherapy was a debate, whether we use neoadjuvant chemotherapy or we go straight for surgery, and then once the consider adjuvant chemotherapy or adjuvant immunotherapy at future. And similarly, palliative treatments, chemotherapies to be offered to patients in those sort of things. So in July 2021, as we have come across through those phases last year, I think we are moving more towards standard of care, offering neoadjuvant chemotherapy followed by radical curative surgery or radical curative organ preservation treatment for these patients with concurrent chemoradiation. Again, in terms of vaccination, different countries will have a different percentage of patients who are fully vaccinated, and this will have an impact as well in terms of choosing your treatments and bringing patients to the healthcare. Similarly, who is at most risk of severe illness from COVID-19 is important to understand. People aged 60 years and over, those with underlying medical problems like high blood pressure, heart and lung problems, diabetes, obesity, or cancer are at high risk of developing serious illness. And anyone can get sick with COVID-19 and become seriously ill or die at any age. Again, those are important things that we need to understand. I think in terms of, as we talked about surgery, radiotherapy, you need to look at risk to patients in terms of different. If you're going for cystectomy, it's a single visit. stay in the hospital for 5 to 10 days, suitable for most cancers, solves drainage or diversion issues. Negatives are that some major surgery needs anesthesia and inpatient stay, 20 to 30% readmission rate and post-op recovery. For radiotherapy, it's an outpatient treatment, no mortality or less morbidity and no anesthesia needed, but it requires multiple visits, transports, waiting rooms, visits for the patient, and fatigue, and not suitable for a small percentage of patient. 20% of cancers, non-UCC, location, hydronephrosis, leaves drainage through bladder, and radioresistant cancers will require salvage surgery. So this was just to give an example between surgery and radiotherapy, how you can look at if you're going through a big pandemic like what we encountered last year. Safe as possible surgery. It's important to look at COVID pathways. It's an interesting paper looking at basically after adjustment, pulmonary complications were lower with COVID-19 free surgical pathways. So again, if you have ICU, theater ward, all are COVID-19 free areas that will have a better impact in terms of mortality with surgery. And post-operative SARS-CoV-2 infection rates were also lower in COVID-19 free surgical pathways. So it's interesting and important sort of adaptation that many hospitals around the world and around the countries within UK as well, we adapted. In terms of pathways, again, this is an interesting one to look at. 500 patients underwent surgery. No patient died from COVID-19 at 30 days. 30-day all-cause mortality was 3 out of 500, so less than 1%. And 2% of patients were diagnosed with COVID-19. So that's interesting and important observations that are coming through, that are telling us through that, going through surgery, during that pathway was safe and surgery was being delivered safely. So COVID-free pathways will be linked to vaccination, prioritize vaccination if enough time and doses, vaccinate at least 7 days prior to surgery, isolation, pre-admission isolation in Sheffield, we do it currently for 7 days. In testing wise, nasal swab and PCR testing, Sheffield 3 days prior to admission, isolation between test and admission. And in admission, avoid public transports and taxis. And I think it's important to understand preoperative nasopharyngeal swab testing does help. And in terms of high risk areas, in terms of a number of patients who need to be swabbed to prevent pulmonary complications for a major surgery is 18. So swab testing was beneficial before major surgery and high SARS-CoV-2 risk areas. There was no proven benefit of swab testing before minor surgery in low risk areas. So again, based on those priorities, you can plan and decide things as you go along. And if COVID is there, delay surgery, delay treatment if possible. That is important to understand that if it's delayed 1 to 2 weeks, pulmonary complications is 18.5%. But if it's 2 to 4 weeks, the risk reduces to 11.7%. And further, if you increase the time period, it goes to 0%. So it's interesting to be aware of these. Similarly, mortality from 7.7% 1 to 2 weeks to 3.4% in 2 to 4 weeks, and then further down to 0 in 0 out of 34 cases if you have increased the time lag from COVID to surgery. So those are some sort of key areas that I wanted to catch up with you as well. Timing of surgery following SARS-CoV-2 infection. This was an international prospective study, and it very clearly showed that patients having elective surgery and those patients with reverse PCR nasopharyngeal swab positive results for SARS-CoV-2, the timing of surgery is important, and symptoms are important as well. So delaying surgery and patients who are symptomatic will have a better impact on outcomes in terms of surgical outcomes and complications. So I think with, key thing will be to reduce hospital contact. That reduces the risk of readmission to the hospital as well. So those are important things in terms of the surgical outcomes. And I will talk to you a little bit more about systemic chemotherapy and immune checkpoint inhibitor. This is a Sheffield single center systemic treatment experience in GU oncology patients that was led by myself. And we know that COVID-19 is a worldwide pandemic. And when we were looking at that work in our first lockdown phase between sort of in March to June 2020, we knew that NICE was giving a guidelines to say that basically we need to prioritize systemic anti-cancer treatment, and we need to communicate with and support patients and minimize face-to-face contact. So there was a bit of a question mark here, because again, many of the patients that we treat in our oncology clinic settings will be coming into priority level 5 and 6, which are non-curative treatment and palliative treatment, in a sense where chance of palliation or temporary tumor control and less than 1 year expected extension to life, or category 6, which many of my metastatic bladder cancer patients fall in, which were non-curative treatment with an intermediate 15 to 50% chance of palliation. So the guideline was that you have to be very carefully seeing them whether it is in their interest to give chemotherapy. The concern was that if you're not treating them, these are advanced cancer patients who will not be well and fit enough to be treated if we delay their treatments by 3 months. And that was the concern which I had discussed with my patients, and we talked about, and that's where we reviewed that data to look at the impact of COVID-19 in clinical practice for urology cancer patients under my care and the outcome at Western Park Center. So it was, record was basically electronic patient record was collected from 1st of March 20 to 30th of June 2020. All patients were screened on arrival to hospital. All patients were counseled about the potential risk with COVID-19 and the implications should they require hospitalization. Patients made an informed decision of proceeding with or stopping treatment, and these discussions were documented in the medical notes. Total number of patients during that phase were 61, 43 were palliative, 10 were neoadjuvant curative chemotherapy, and 8 were adjuvant curative chemotherapy. Median age was 71 years. Male to female was 2:1 ratio. Comorbidities were present in 51 patients. Most commonly were hypertension, hearing impairment, hypercholesterolemia, and diabetes mellitus. Primary cancer, bladder cancer, 44 patients, upper urinary tract, 7 patients, and 10 were prostate cancer, lymph node mets, 9 patients, and visceral metastatic disease in 35 patients. Again, these were the systemic treatment we offered and we treated patients with. Total number of systemic treatment administered during that first COVID wave between March to June were 195 cycles of systemic treatment, and all these patients were reviewed in the clinic prior to the treatment to ensure that it is safe for us to treat them. Repeated bloods were done at the time of clinic visits as well when we were doing their clinical assessment. So we offered atezolizumab 51 cycles to 12 patients, pembrolizumab 8 cycles to 2 patients, and different chemotherapies including cisplatin gemcitabine, carboplatin gemcitabine, carboplatin etoposide, paclitaxel, docetaxel. Similarly, patients who were on trial, they continued on their trial treatment with Javelin, which was chemotherapy plus avelumab, Niagara, which was chemotherapy plus durvalumab, or chemotherapy alone in a randomized trial. Similarly, for non-muscle invasive bladder cancer trial, we were offering Potomac trial, which was looking at additional durvalumab treatment with BCG. Similarly, other trials like Infortumab and paclitaxel were treated as well. One male patient discontinued treatment due to immune-mediated toxicity, continues on tapering dose of steroids. One female patient with metastatic bladder cancer developed immune-mediated grade 3 hepatitis. She was treated with tapering dose of steroids and mycophenolate, and then re-challenged with atezolizumab successfully. One patient stopped chemotherapy after 3 cycles out of planned 4 cycles of neoadjuvant chemo, has developed transient ischemic attack, proceeded to radical cystectomy. So this did not compromise the radical curative treatment. One patient stopped following admission with neutropenic sepsis and grade 2 fatigue after 7 cycles of docetaxel chemotherapy in castration-resistant prostate cancer setting. 3 patients on systemic chemotherapy stopped due to disease progression. One patient stopped after 3 cycles of palliative chemotherapy with gemcitabine plus cisplatin after being admitted with treatment-related side effect. She tested positive with COVID-19. She was treated with antibiotics. CT scan showed stable disease, and she was discharged home after 4 days of inpatient stay and recovered. So total number of admissions were 14, elective admissions were 3, emergency admissions at Western Park Hospital were 5, emergency admissions at District General Hospital were 5, and assessment and review in assessment unit 1. So our single center demonstrated that treatment with systemic chemotherapy, immune checkpoint inhibitors, and the use of steroids for toxicity management may be possible during the current COVID-19 pandemic. And only one patient in our cohort of 61 patients who received 195 cycles of systemic treatment tested positive for COVID-19. I think it's important to understand that patients need to make an informed choice after careful discussion with their oncologist about these treatments, after careful review of risks from the disease versus risks from the treatment and potential benefits from the treatment. I think we need to realize that COVID-19 is here to stay. Vaccination is helping. Treatment choices as prior to COVID, we need to consider them, consider best choices, individualize patients' risks, safety of local pathways. Local COVID-19 prevalence and vaccination rates are important to review. Design and adhere to COVID-19 free pathways, differ when COVID-19 positive, reduce hospital stay. And I think it's very important that we need to realize the sea of cancer is significantly dangerous. The detrimental impact from delays in cancer diagnosis and delays in cancer treatment cannot be underestimated. And we need to carefully assess it versus risk of COVID. Chemotherapy and immune checkpoint inhibitors are safe if managed appropriately. So I think even in those pandemic era, and again, there were other papers that came out as well. Paper came out from Tom Powles and colleagues from Bart's Cancer Institute looking at immune checkpoint inhibitors in kidney cancers and other tumors, which very clearly showed it was safe to administer these treatments as well. So there's more data that has shown that I've discussed today in terms of both surgical pathways and systemic treatment pathways, that actually understanding and rationalizing the treatments are important, but understanding the risk from delays in diagnosis and delays in cancer pathways are significant as well. And hopefully the data that we have discussed today will generate some debate, and I will be very happy to take any questions. And on that note, I will stop. Thank you very much for listening.
Thank you very much, Professor Syed Hussain, as always. This is an excellent presentation, and obviously there are very important points that we can discuss in our Q&A session. I would like participants to start sending questions. So you can send it to the Q&A box, and we can ask experts after the presentations. So let me introduce my second speaker. He's Professor Mackin Keane, Professor of Medical Oncology in University College Hospital, Galway. His special interest is management of breast cancer, clinical trials, drug development. He's also National Advisor to National Cancer Control Program in Ireland. So his topic is impact of COVID-19 on systemic therapy for cancer and guidelines for its management in the future. Professor Mackin Keane.
Good morning, everybody. And I would like to just introduce myself first. My name is Mackin Keane. I'm a consultant medical oncologist and Associate Professor of Medicine at the National University of Ireland, Galway in Ireland. I am also the National Advisor in Medical Oncology to our National Cancer Control Program. Our National Cancer Control Program largely has jurisdiction over cancer management in the whole country, where we have divided the country into 8 regions for delivery of cancer care, which are generally quite autonomous, in that most care can be delivered within any individual region. So last year, Rizwan Sheikh very kindly asked me to speak at this symposium, and it's a great pleasure to do so again. In the year, we've learned an awful lot from COVID-19 and what it has done to our services. And today, what I'm hoping to share with you is the impact of COVID-19 on specifically the systemic therapy for cancer and how it's administered in Ireland, and guidelines that we've put in place for management in the future. And particularly, I'd like to share with you a model of care that we are planning to institute in the near future, and it's currently becoming policy, part of which was informed by the COVID-19 pandemic. So with that as background, these are the Johns Hopkins data for Ireland up to the 22nd of October, so pretty recent in terms of total number of cases of COVID-19. And as you can see, we've had 3 significant spikes, the worst of which was in the spring of this year after Christmas and the New Year. And currently we're undergoing a slight rise. Now, the initial spikes were largely managed by lockdown. The biggest of these and the worst of these, and the one that had the most impact, was this one that happened in the spring of this year after a lot of exposure, particularly international exposure from people coming home to Ireland. We have a lot of immigrants who would come home at Christmas and New Year, and that brought home a lot of COVID, which was treated by lockdown. But predominantly, or very importantly, in February, and to a certain extent in late January, we commenced our vaccination program. And the vaccination program really has had a major impact, in addition to lockdown, at preventing spread. As we have moved towards opening up, particularly in the fall of this year, we have seen a slight rise in the number of cases, but it hasn't had quite the same impact in terms of either admissions to hospital or, more importantly, ICU care as it did back in the spring. So if you look at our vaccination, it has been a highly successful program. To date, we have now over, as of October 21st, we had 89%. We're now over 90% of the population vaccinated with at least one dose. In fact, most with 2 doses. And we currently have our booster program beginning. This really has had the most important impact in COVID-19 control, and most importantly in COVID-19 admission reduction. And if we look at that, the numbers of acute hospital cases, it has pretty much mirrored the waves I've just shown you, both hospital cases and intensive care cases. We had more intensive care cases early on when we didn't have patients vaccinated, but since the vaccination program has been in place, we have less ICU admissions, we have less hospital admissions, albeit with a slight rise now. But certainly at this point, what it is about is living with COVID and trying to live safely with COVID. And that's really what we're trying to do. So what I'm going to reflect today is some changes in our systemic anti-cancer therapy program to cope with those changes. So in terms of what we did with that program during the pandemic, well, the first thing is that all the units throughout the country remained open, albeit with great difficulty and with a lot of change in process. All have remained open. Largely, systemic anti-cancer therapy throughout the country has gone ahead uninterrupted for the 2-year period. Perhaps, if anything, I would say the systemic anti-cancer therapy has been more difficult to give, because of social distancing and other changes we've had to institute, but we've largely managed to keep going. If we have one failure, I would say that failure is in our A&E services, because our A&E services admit both our cancer patients, our non-cancer patients, and our COVID-19 patients. So they're a choke point at the admissions to our hospitals, and that has led to a real problem in terms of cancer patients in particular being exposed to COVID-19. If you look at what actually happened, and as I said earlier, the spring of this year is when this was at its worst. 8 of our oncology day wards moved off-site. 3 of them are still off-site. The rest, the other 5, have returned. There's been a significant reduction in the capacity to deliver anti-cancer therapy within the units, mostly due to social distancing. This has been about 18 to 20% reduction across the board. We had to move 4 inpatient oncology and hematology wards off-site during the height of the spring surge. All of those have now been repatriated nationally back to their original hospitals. What this has led to is a review that we did that clearly demonstrates that we need increased capacity, particularly in our day wards and our ambulatory centres. Currently, we reckon that we need about a 70% increased capacity. This is partly to deal with COVID. More importantly, it's to deal with our National Cancer Registry data, which is demonstrating that we will have about a 42 to 48% increase in the number of patients who will require systemic anti-cancer therapy by 2025, and that's only a few years away. We also acknowledge that currently the majority of our day wards are operating at about 20% over capacity, so that capacity needed to be replaced. So in general, even today, we need a 70% increase in capacity within our day wards. But really, when we looked at this as a cancer control program, we felt that one of the core problems was we would never be able to continue to expand at this rate within our current structures. And what we looked at was changing the model of care within which we deliver systemic anti-cancer therapy. And I will go through that in a minute. But our key learnings, first of all, from the coronavirus pandemic. I would say key learning number one in terms of our day wards is we really need separate entrances. The idea that patients who are vulnerable, immunosuppressed, lymphopenic, come through the same admission system as patients with COVID-19 or contacts or with other conditions doesn't make any sense. We need to maintain social distance within our units, particularly such that our chairs are at least 2 meters apart. And we need to ensure that we can isolate the vulnerable populations, particularly those patients who are lymphopenic, who we know don't respond well to vaccines and are more vulnerable to this virus, for example, CLL. And finally, we need to ensure that all staff are vaccinated as well as all patients. So with that as a background, and with the clear knowledge that we needed more capacity, our National Cancer Control Program decided to embark on a plan to develop a model of care to deliver systemic anti-cancer therapy for the country that would be robust enough to ensure that we had a capacity plan to deal with problems such as COVID, or as we had also a ransomware attack over the next 15 to 20 years. So what is a model of care? Well, a model of care broadly defines the way a health service is delivered. And what we wanted to do was use the best practices and the best international data to develop a service for patients with cancer to deliver their systemic anti-cancer therapy. What we were really looking at was to provide the architectural framework for anti-cancer therapy that would be flexible enough and responsive enough to deal with the population change, the change in the way the treatment is given, and potentially events such as COVID or a ransomware attack that could interfere with that delivery. And from our analysis, we came up with 25 recommendations. I won't go through them all in detail, but I will go through some of them. And these recommendations were informed by gaps that we identified between our current services and what was international best evidence for delivery of anti-cancer therapy. So what were the drivers? Well, COVID, huge driver. It forced us to rethink the way we did everything. And frankly, we did pretty well in terms of delivering our care despite the pandemic. We also had national policy recommendations, which came from our National Cancer Strategy. This is published every decade. The last one was 2016. But there were policy recommendations in terms of the National Cancer Strategy to ensure every patient got the highest quality of care in the country, and also to deliver that within a new universal health system, which we've dubbed Sláinte Care. It's an Irish word, means healthcare. But this model of care for delivery of anti-cancer therapy was embedded within the Sláinte Care plan. This model of care has to be robust enough to deal with increasing patient numbers as our population ages and as we have an increase in size of our population. It also needs to cope with the changes in systemic anti-cancer therapy, both the new indications for the treatments, also the newer treatments such as immunotherapy, oral tyrosine kinase inhibitors, and so on and so forth. And also it needed to be able to cope with the cost of that. Finally, we had to look at our legacy infrastructure, our currently existing day wards, for instance, and our capacity deficiencies, and identify what facilities we needed to put in place to deliver, as I say, a robust service for the next 15 to 20 years. So the first thing we did was look at the cancer pathway. And this is really about identifying the scope of what we needed to do. So in terms of what we were planning, what we did, if you take a patient if you take the cancer pathway for any given patient from prevention through referrals, through diagnosis, through treatment decision makings, what we wanted to do was to take it from the point of the multidisciplinary conference through to whether that patient was on active treatment, surveillance, or palliative care, but if they were receiving systemic anti-cancer therapy, if they received it at time of recovery, or sorry, of recurrence, that we covered the whole gamut of this component of the patient's treatment journey. So what we were looking at really was a very significant burden of patients that required care everywhere in the country. So the scope of the document was in an effort to ensure that this was properly delivered. And if you look now at the way we have changed the way systemic anti-cancer therapy is given. In the 1960s, most systemic anti-cancer therapy, in other words, drug treatment for cancer, was given to treat leukemias and other diseases such as that, and was delivered as an inpatient. Through the decades, we have moved to a point now where 90% of systemic treatment for cancer can be delivered in an ambulatory care environment. And increasingly, as we come to less toxic and more oral systemic treatments, we are now moving away from the ambulatory centers through to primary care. These patients are receiving their treatment at home. They are receiving their treatment chronically. It's not a once every 3 week or once every 2 week treatment. It's a continuous treatment. And what we need to do is put in place a governance structure and an architectural environment within which we can guarantee that full spectrum of care is delivered to patients in a way that's safe and meets international best practice. So with that, we identified 10 areas that were really important. One was that the patient's experience of receiving their treatment was good, and that it should be maintained from the inpatient to the home environment. That services were organized such that patients were within a continuum of service and not in a piecemeal service. That the governance of that anti-cancer treatment, whether it was delivered as an inpatient, in a day ward, in a doctor's surgery, a GP surgery, or at home, was under a single governance, typically under the management of a hematologist or medical oncologists. The quality and safety was guaranteed throughout the journey. The data information was all retained, robust, available, and safe. That any innovations in systemic anti-cancer therapy would be delivered to that patient through the system. That they would have access to clinical trials throughout that continuum of care. That pathway was fully documented, so the patient was fully aware of everything that was going on. That patient who was in this system had access to acute oncology services to ensure that if they did get a complication of their disease or of their treatment, that they would be admitted appropriately to an appropriate unit. And then, of course, this had to be underpinned by workforce planning to ensure we had adequate numbers of staff to deliver this service. So with that, what we've come up with is an organization of services within each of the cancer centers, or the cancer control regions, should I say, that is effectively over 4 levels. We have our cancer center, which is our major cancer hospital, with all levels of systemic anti-cancer therapy, inpatient, outpatient, subspecialty treatment. We have level 2 hospitals. These are hospitals with inpatient oncology services, but do not have the full strength of a cancer center. We then have smaller hospitals where we would have nurse oncology-led ambulatory care units under the governance of the cancer center, but without medical oncologists on site. And finally, we have community services, which are small infusion suites that may not be co-located in a hospital at all, maybe in a GP surgery, maybe in a small nursing home type environment where low-level systemic anti-cancer therapy can be delivered. So what we've defined very clearly in our organization of services is what can be delivered at each level and how the governance of that works. And this really is the core of how we plan to expand systemic anti-cancer therapy services nationally to ensure we get good quality care. The core element of it are ambulatory day units. And the ambulatory day units, whether they be in a cancer center a level 1, in other words, level 1, level 2, or level 3 hospital will be effectively independent walk-in units at these sites. They will contain the outpatients, the day wards, the ancillary spaces for oral anti-cancer clinics, doctors' offices, procedure rooms, clinical trial space, and the prep rooms for drugs. These will, of course, be supported by adequate staffing, phlebotomy, pharmacy, IT support, particularly access to our cancer information system, our radiology support systems, our laboratory support systems, and also support staff, portering, administration, cleaning, and underpinned by a series of policies and guidelines to ensure care is properly delivered at these sites, irrespective of where they are. The governance is a single governance structure that's established for the total SAC services, which will effectively be from the community through to the hospital, through to the cancer control network in the region, and ultimately the National Cancer Control Program. So any patient treated at any site in the country will be effectively under the National Cancer Control Program. So our key learnings, number 1 is our goal is to treat cancer to the very best international standard, despite COVID-19, despite ransomware attacks, in a robust fashion that ensures patient safety and the very best international standard it delivers that patient. What that has led us to do is to develop a new model of care that is dispersed from the cancer centers right down to the level of the GP and community centers, governed by the cancer center. This is all in an effort to ensure we continue to deliver that high quality of care, and we mitigate all risks, or as best we can, risks to vulnerable patients. So I hope this has been of help to you. I want to thank you for engaging with this, and hopefully I will be able to answer some of your questions at the question and answer session. Thank you again.
Great. Thank you, Professor McEnkeen. As always, this was very, very interesting. Your talk, particularly in relation to new model of care. Obviously, we will have question and answers at the end. Let me introduce my third speaker. He's Dr. Mohammad Raza. He's a consultant virologist in Sheffield Teaching Hospital, NHS Foundation Trust, Sheffield, UK. He's obviously involved in a lot of trials for vaccinations and involved in the fight against COVID-19 pandemic in UK. So I would like Dr. Mohammad Raza to present.
Right. My name is Dr. Mohammad Raza, and I'm one of the consultant virologists in Sheffield Teaching Hospital in Sheffield. And many thanks for giving me the opportunity to talk on the subject of COVID-19 vaccines in cancer patients. Now, before we go into the details of cancer and the vaccination, let me take you back to 1875 and show you an example, a success story of vaccination in controlling the infection. So the HMS Dido brought measles to Fiji, killing 20,000 people, which was about a third of the island's native population. And subsequently, the measles outbreak would continue to hopscotch Pacific Islands for much of the next century. So this is the havoc which is caused by a new infection when introduced into the native population. Now, clearly, this is an example where the R0 value is much higher than seen in any of the other infections, but ranging between 17 and 18. However, in 2021, if you think about it, MMR vaccine has successfully controlled measles, and the infections are mainly seen in areas where the uptake of the vaccine is poor. Now, what typically happens after a COVID vaccine is introduced in the body via an intramuscular injection is that the messenger RNA forces the body to produce the S antigen, which is then taken up by the antigen-presenting cells like the dendritic cells. These are then transported to a lymph node or lymph nodes, where in the germinal centers, a series of events ensue, which lead to the production of the necessary B cells and the T helper cells. This means the immune system is then primed to produce all these necessary responses once they encounter the antigen again in the future. So is it as simple as just measuring these markers and then assume that the patient is protected? The problem is that the correlation between these markers and the actual protection have not been properly defined. And just the mere presence or detection of these markers does not necessarily equate to protection. So what we have found out is, or the available diagnostic assays, neutralizing antibodies have been taken as box standard. This is because you can actually see the antibodies restrict the growth of the virus, and you assume that this is what is going to happen in the human body and protection will ensue. And even then, the neutralizing antibodies are not readily available, and the box standard of protection in an individual is taken as the qualitative tests which are done in modern diagnostic laboratories. The graph here shows the relationship between efficacy against any symptomatic SARS-CoV infection. So what typically happens after you give the vaccine, COVID vaccine, to an individual is that antibodies are produced. Now, how true is that is shown by this paper in Nature, and this graph shows the production of antibodies in two particular groups. The black lines represent the responses in somebody who's had the COVID infection in the past, and the red ones are where they've never encountered the infection before. And you can see the responses are a bit better in the past infected patient group. So this is what happens in a normal, healthy, immunocompetent population. Now, because we know the immunocompromised patients do not have optimal T and B cell responses, there is apprehension, or has been apprehension within the global medical community about the efficacy and safety of this vaccine. And a good example is that of influenza vaccines, that over the years, even though the flu vaccine is given to these individuals, the seen responses are nowhere near as seen in the immunocompetent healthy population. And remember, the immunocompromised population is a broad group, which includes not only those individuals with primary immunodeficiency since birth, but also secondary immunodeficiency due to chronic conditions like HIV infections, diabetes, leukemia. It also includes those patient groups where this happens because of medical treatment, and the examples of that of transplant recipients, autoimmune disease, cancer patients, chemotherapy, and oral steroids. The COVID vaccines are not live vaccines, so can be safely given. And to be fair, the safety profile has not been a concern in any of the population, apart from all these injection site reactions and anaphylaxis, which again has been seen in a very low number of patients. So this group is no different. The concept of vaccination, after all, relies on provoking immune system, and doubts, again, as I said, have been raised in immunocompromised population about the efficacy. So let's look at some of the immunocompromised population and the responses before I go and talk about the cancer patients. So the seropositivity rates, reassuringly, in HIV patients was seen to be quite high, 94% versus the 98% in healthy cohort in this paper by Heather et al. 80% with autoimmune disease or solid tumors were also positive. However, the hematological malignancies and the solid organ transplants did not do very well, and you can see the responses were much lower. There was a significant correlation seen between steroid treatment for especially prednisolone, and failure to mount a detectable response post-vaccination. In another study by Ali Hussain et al., there were only 25% of kidney transplant patients who had detectable antibodies after full vaccination. In yet another study of 45 kidney transplants, you could see the very low responses of 17.8% after the vaccination, but the T-cell responses were better. Similarly, another series of observations in solid organ transplant recipients, they were seen to have poor antibody responses. So this is 58 recipients of kidney, liver, heart, and lung transplants, where the measurable antibody responses by the Roche assay were seen to be lower after the first dose, improving after the second dose. However, the important thing to note here is that 46% of these patients did not have any response. And older age, shorter time from transplant, and inclusion of mycophenolate as a therapy in immunosuppression, and the Pfizer vaccine was seen to be the risk factors for no response. And remember, these drugs could be used in other settings as well. So it's not necessarily related to solid organ transplant. Now, the concept of suboptimal responses is not new, and you can see this paper from Lungwen in 1989, where declining antibody titers was seen 2 years, even after 2 years of stem cell transplants, and seropositivity rates were best with rubella, but as low as 42% with mumps. In a recent observation by our Sheffield group, 56 patients who had gone autologous transplant after a median of 7 years, almost all participants had inadequate titers against diphtheria and pneumococcal infection, and a significant proportion had inadequate titers against measles and VZV, which was as low as 10.9%. So you see the concept of low response against vaccine as a concept is a reality. So moving towards responses in cancer patients. So it was reassuring to see that in this paper that there were no differences in terms of IgG positivity, nor in median time from COVID-19 diagnosis to IgG detection in a series of patients with cancer, solid cancer. In a letter published in this paper, 524 patients were analyzed at 3 months after vaccine, and 38% of these were solid tumors. It was again refreshing to know that the seroconversion rate for solid tumors was 93%. However, the hematological malignancy did not do very well, and even though the antibody responses were good, the T-cell responses in solid tumor were only 46%. This was detected by the interferon gamma releasing assay, which is quite standard in these cases. And 76% of seronegative patients did not have a T-cell response. So what this is showing you is that within the cancer group, the stem cell transplanted patients and those with hematological malignancies don't do as well. So this study from Schroff et al. Published in Nature Medicine specifically looks at the cancer patients, and the BNTB162b2, 2 doses were given and blood samples were taken. The draw one was at the time of vaccination, 3 weeks later. The second draw was taken, and the third draw was between 5 to 11 days. And what they have seen is they've compared the responses between this patient group and the healthy. You can see here the antibody responses between the 2 groups show low concentration in the cancer group and much steeper curve in the control group. So basically the responses were seen, however, the responses were not as quick and not as high in concentration. Now, after these observations, there were talks about a 3rd dose of the vaccine, And one of the first groups to be investigated was the allergenic stem cell transplants. And what was seen was that there were significant differences between the post-second dose and 1 month after the third dose, which is represented by this graph. So Kamar et al. Saw that administration of a third dose of BNT162B2 improved the immunogenicity of the virus. So 52% of the patients requiring still had a low concentration. So even though the responses were seen, these weren't seen in all patients, as shown by this graph. On the left, it shows the prevalence of anti-SARS-CoV-2 antibodies after various doses, and you can see the highest is after the third dose. And on the right is the antibody titers, and you can see the mean is much more after the third dose, a month after the third dose. Now, continuing with the study which I showed earlier on, they continued with a third dose, and they took, after the third dose of the vaccine, they took a blood sample at the time of the third dose and a week after the third dose. And you can see here the responses were present. They were patients who picked up from low concentration into high concentration. It was encouraging to see antibody and T cell responses, but the magnitudes of vaccine-induced antibody and T cell responses were substantially reduced. After the third immunization, the neutralizing antibodies levels improved in 16 or 20 patients. However, the responses were, or the increases were modest. So what the authors concluded was that the expectation should be accordingly adjusted, and the degree of benefit with these responses wasn't very clear. So based on all these data sets, the Joint Committee on Vaccination and Immunization in the UK issued advice on third dose of the vaccination for the severely immunocompromised patients. And on the right, there's a list of patients who have been selected out for this particular purpose. And you can see here, this ranges from the acquired cellular and combined immunodeficiency with low lymphocyte count, all the way with the use of JAK inhibitors, B-cell therapy, T-cell co-stimulation modulators, the TNF inhibitors, and some of the chronic inflammatory disease, especially those patients on prednisolone, methotrexate, azathioprine, and mycophenolate. And high-dose steroid use has been identified as one of the major factors. So in summary, immunocompromised population generally are and perceived to be at high risk of infection complications. So there is a need for protecting them against the infection to start with, and if not the infection, to provide some form of protection and stop the severe disease from happening. The COVID vaccine overall has been a major success in preventing hospitalization and severe disease in healthy population, but in immunocompromised patients, this group is seen to mount suboptimal responses, and a third dose has been shown to boost seroconversion rates. There are no safety concerns which have been raised, and the third dose has now been recommended in the UK as part of primary vaccination. And one thing to note here is that it looks very rosy when looking at it from our end. However, greater granularity and correlative protections are required to inform clinical decisions. There's no point in continuing to vaccinate patients and them still getting these complications, etc. So real-time data will emerge, and this is something which we will need to keep an eye on. An active immunization may not be possible in some group of patients. So, for example, those who've received anti-CD20, and alternative strategies are required for this prophylaxis. I'll end my talk here, and thanks once again to the organizers for inviting me to give this talk. Thank you very much.
Thank you very much, Dr. Mohammad Raza, for an excellent presentation. So I'm going to invite my next speaker. He's Dr. Ahsan Waqar Khan. He is a consultant anesthetist and intensivist here in Shaukat Khanum Cancer Hospital. He's going to talk about his our experience of dealing with COVID-19 in our cancer center, and also a little bit of managing COVID-19 severe pneumonia in cancer patient. So I would like to invite Dr. Ahsan Waqar. Thanks.
Assalamu alaikum. My name is Ahsan Waqar Khan. I'm a consultant in anesthesia and intensive care, and I work at Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. What I'm going to do today is to share with you my experience and what we have been doing and how we have dealt with COVID-19 infection. I do not have any conflict of interest to declare. We would be going through the coronavirus pandemic. How did it begin and how the world dealt with it? The clinical features associated with it, the treatment guidelines, the COVID-19 trends in Pakistan, the Shaukat Khanum experience, followed by some statistics that we have to show, and a conclusion. So we all know how did this pandemic start? So it was December 2019. It was Wuhan, China, where it was first isolated. What they experienced was that they started to admit patients in intensive care with pneumonia of unknown origin and unknown description. So when they started to investigate that this sort of a pneumonia, which was highly associated with a very high mortality, when they started to investigate that, this is the time when they came up with the coronavirus. So why is it called COVID? CO for corona, VI for virus, and D for disease. And this, since it was year 19, so COVID-19. Officially declared a pandemic by WHO in March 2020. Since May, till May, we have got more than 200 million cases worldwide, followed by almost 5 million deaths worldwide. That's a lot of deaths, and that's a lot of people getting infected with such a contagious disease. So you can imagine, we can all imagine, we've all experienced this, that this disease posed very different challenges. As of September the 30th, 2021, Pakistan has experienced more than 28,000 deaths. More than 1 million cases have recovered since then. And on 30th of September, we had close to 50,000 cases that were actively infected with the disease. Since then, the fourth wave has subsided, so the numbers would be less by now. So what are the risk factors that we know are associated with this disease? I would like to talk about the possible risk factors with mixed evidence, with low evidence, and that is asthma, hypertension, immune deficiencies, liver disease. Then the possible risk factors, which is easy again, cystic fibrosis, thalassemia. The troublesome and the worrisome is the established and the probable risk factor. That's a long list. That's a long list. But more importantly, cancer pretty much stands out. It's at the top of this list. And Shaukat Khanum Hospital is a cancer hospital, and we are dealing with the cancer patients. So for us, this problem has a magnitude which is a bit higher than how the general hospital would be facing. Apart from cancer, we have the usual suspects, that is cerebrovascular disease, children with underlying conditions, kidney, lung, diabetes, Down syndrome, heart conditions, neurological conditions, pregnancy. Smoking is an interesting one because even if you have stopped smoking, you're still at higher risk of developing this infection. Having said that, there was a study which opposed this idea. Anyhow, we don't have time to go into that in detail. Substance abuse and use of corticosteroids. All these are established and probable risk factors. So what are the clinical features associated with disease? So it offers a wide spectrum. You can have a symptom and you can have quite a few symptoms. You can have a symptom that is increase in magnitude. You can have quite a few symptoms, but maybe the disease is not severe enough. So again, this is a fairly difficult science, which symptom patient is going to present with, and the presentation correlation with how this patient is going to progress, again, difficult to predict. So persistent symptoms, we have divided into symptoms, the proportion of the patients who have been affected by this, as far as we know, and the approximate time to their resolution. So the important one is the fatigue, dyspnea, chest discomfort, cough, anosmia. Roughly for all these, what we believe is that the symptom resolution takes 2 to 3 months. For anosmia, a bit less than that. And for all these, we have a very wide quoted incidence from 15 to 87% fatigue, dyspnea 10 to 71%, 12 to 44% for chest discomfort, cough 17 to 34%. So the percentage of all these as quoted in different studies is fairly variable, probably depending on the local circumstances, local environment, and the local factors that are involved in evolution of this disease, as we know. The less common symptoms is joint pain, headache, rhinitis, poor appetite, dizziness, vertigo. This is less than 10%. And we don't exactly know when do they subside. I think post-traumatic stress disorder, which is part of the neurocognitive disorders, is something that is we probably are going to see more and more as the time advances. So people who have been infected, who have made a recovery, they're still suffering from those thoughts, that experience that they've gone through, and that still rankles with them, that still haunts with them. And that is something that with time, I think we are going to see more and more. At the moment, we think that it lasts from anywhere from 6 months to 3 months. But knowing PTSD per se, it does not really limit itself to 3 months. So there is a real danger here. Then concentration, memory, anxiety, depression, all these things we have seen with these patients who have been affected with COVID-19. So let's talk about the treatment guidelines. So the treatment guidelines that have been published in August 2021 by a panel of experts tell us quite a story about how this disease has evolved and how we have understood this disease, and hence how we have been trying to treat this disease. So the first thing to say, safe thing to say would be that initially when the disease started, we didn't really know what to do with this. And there was a lot of anxiety, how to deal with this, what to treat it with, what not to treat it with. Is there evidence? Can there be evidence in any pandemic? And later on, we realize there's a very interesting editorial by Najm, New England Journal of Medicine, a few months ago, where they argued that what we have learned from COVID-19 is that still we can produce good evidence even at the peak of a pandemic. And the argument is that we still need to stick to science. If we don't have a treatment, what we cannot do, what we must not do is to start making up treatment as we go along. We still need to stick to the known science of things. So talking about these medications, remdesivir, ivermectin, nitazoxanide, lopinavir, ritonavir. So there is no real evidence of protease inhibitors, nitazoxanide, ivermectin. The panel is not recommending them. The panel does recommend remdesivir, and we'll talk about this a bit later. So to keep it simple, the rate of recommendations, A, strong, B, moderate, C, optional, and the rating of evidence was quite interesting. 1, 2A, 2B, and 3. 3 is expert opinion. And 1 is one or more randomized trials without any trial limitations, without any major limitations. Followed by 2A, which is other randomized trials or subgroup analysis of the randomized trials. And then the 2B, non-randomized trials. So because of the pandemic, you can see that the rating of evidence is a little bit truncated. It's not as pronounced as it normally is. So from 1, 2A, 2B to 3. 3 is expert opinion, 1 is randomized trials. Okay, so we're going to talk about the panel's recommendation based on the patient disposition. So if the patient is not requiring hospitalization or not requiring any supplemental oxygen, as determined by the clinician, then there is no real evidence of giving them any medication over the other. We don't have any recommendation with regards to that. The next set of patient is who have been discharged from the hospital, from the inpatient in a stable condition, and they do not require any oxygen. So what does the panel recommend? The panel recommends against using remdesivir, dexamethasone, or any other medication after hospital discharge. So if they're being discharged in a stable condition, they don't need to be on medication. That is the recommendation. Then the patient is being discharged from the hospital and requires supplemental oxygen. Then this is that group of patients who are stable enough to be discharged, but who still require oxygen. Obviously, these would be the patients who need to be discharged because the hospital requires them to be discharged, because of the capacity issues, because of the pandemic situation, because of the number of patients who are inside the hospital. So some of the patients are bound to be discharged who are on oxygen. So what do we do with them? So we don't really recommend that you give them remdesivir or dexamethasone. If they are stable, let them be. And the recommendation of giving any medication is not there. Now, the next bit of patient is that the patient is being discharged, but they are requiring increasing supplemental oxygen. So the supplemental oxygen is not stable. It is being given in incremental doses. So this is potentially a patient who may benefit with dexamethasone, and possibility of remdesivir cannot be ruled out, although the recommendation is is not as strong. It's an expert opinion. The other thing to note is that, again, why would these patients be sent home if they're still requiring incremental oxygen? Because of the situation, because of the local situation, because of how the number of patients that are inside the hospital and how you can cope with it, and the numbers that you can cope with actually. So this is an interesting one. The next bit of recommendations with the disease severity, the hospitalized patients that do not require supplemental oxygen. So the panel recommends against the use of dexamethasone or any other medication. Then comes the group hospitalized and requires supplemental oxygen. So the recommendation is fairly simple. You give them remdesivir, you give them dexamethasone plus remdesivir if it is available. And if it is not available, then you give them dexamethasone. Then the hospitalized and requires oxygen delivery through a high flow device or non-invasive ventilation. Again, the recommendation is the same. You give them dexamethasone and then add remdesivir if you have remdesivir that is available. And also think about, this is the time to think about baricitinib or tocilizumab. Patients are hospitalized on mechanical ventilation or ECMO. So dexamethasone is a very strongly recommended and is based on the recovery trial. So hence 1A. For the patients who are within 24 hours of admission to the ICU, you think about tocilizumab along with dexamethasone. But for this group of patients who are now intubated, remdesivir is probably not a recommended drug. So this was all about how we are going to treat our patients with COVID. So moving on to the COVID trends in Pakistan. The first case was identified on 26th of February 2022. By mid-March, almost all the provinces had one case. At least the first wave had really started by the end of May, the second wave in November, the third wave in mid-March, and fourth wave in July, and that has just subsided. Okay, so what happened at Shaukat Khanum? So overall mortality was 72%. 26% of our patients survived who were admitted with COVID, and 2% were lost to follow-up. So we don't exactly know. Overall, we admitted 64 patients from 1st of April 2022 to 31st of July 2021. The mean age was almost 50 years, males a bit more than the females. So this is the important bit, that 87% of these patients were cancer patients. So we only had 8 patients who were non-cancer patients in the initial days of the pandemic. 30% of these patients developed renal failure, pneumothorax 6.2%, minimal heart failure, one patient developed heart failure, and there was no documentation of a CVA or a liver failure. Total hospital duration, which was 18 days, mean was 18 days, ICU stay mean was 10 days, and duration of ventilation was 8.4 days. So how did we treat them medication-wise? Remdesivir was received by 45% of the patients, dexamethasone almost 80% of the patients, tocilizumab 20% of the patients. Remember, it was the first wave where tocilizumab was really the favorite of quite a few guys. So patients just did receive them. After during the second and third wave, less and less use of tocilizumab. Enoxaparin, we used therapeutic enoxaparin. This was decided at the level of institution that we would be using therapeutic enoxaparin for these patients who have a raised D-dimer. So 70% of our patients received enoxaparin and 12.5% of our patients received heparin. Quite a few participation in trials and quite a bit of academic discourse. Solidarity trial, we participated. We were the lead investigators for the country. Solidarity Plus is ongoing. Vaccine trial about CanSino, we were able to recruit more than 1,000 patients. Stage 2 is now being thought of. We've successfully been able to publish more than 10 publications in high impact factors, and this work is still ongoing. So this is the experience that we had at Shaukat Khanum Hospital. I'll be very happy to take your questions, answers. Thank you.
Thank you very much, Dr. Hassan Bakar, for an excellent presentation. Now I'm going to invite my last speaker. He's Dr. Khurram Bilal Tariq. He's a consultant hematology and oncology, Sebi B. Jones Regional Cancer Center, North Carolina, USA. And his topic is effect of hematological cancer treatment on COVID-19. So Dr. Khurram Bilal Tariq.
Assalamu alaikum wa rahmatullahi wa barakatuhu. Bismillahir Rahmanir Rahim. My name is Khurram Bilal Tariq. I'm a hematologist and medical oncologist at the CB Jones Cancer Center in Boone, North Carolina. I'm also the department chair for the Cancer Center and also the director of the research department at CB Jones. Alhamdulillah, I was the program chair for American Society of Hematology ASH Life Review Pakistan conference in July of 2021. This was the first ASH endorsed event, not just in Pakistan, but also for the entire region of South Asia and the Middle East. I'm also the founder of Hope Virtual Platform that many of you are a member of. Besides that, in the wider Appalachian Regional Healthcare System Network, I wear several different physician leadership hats. Alhamdulillah. This is a bird's eye view of the hospital and the CB Jones Cancer Center in the beautiful city of Boone, North Carolina, that I call home. This is my motherly mentor, Dr. Fawzia Rana. Many of you may already be familiar with her. She was the founding physician at Shaukat Khanum. The picture on the right depicts her talking to a patient with Princess Diana. And she played an instrumental role helping Prime Minister Imran Khan work through the weeds and to establish Shaukat Khanum in the earlier days. On the left is a picture of myself with Dr. Fawzia Rana. Fawzia Apa is what I call her. I'm here as the youngest department chair that I know of because of the trust that she put in me. And none of this talk will be complete without a mention of that. And together we have formed a lifelong relationship, and once a mentor, always a mentor. So thank you for doing what you did. All right, so diving into our topic, effects of hematologic cancer treatments on COVID-19 patients with a focus on immunotherapy as it pertains to Hodgkin's lymphoma, CLL, specifically BTK inhibitors, and tocilizumab as it is used for the treatment of CRS and also for COVID-19. We'll go through several different studies and try to bring you the most updated data. The picture here speaks 1,000 words, and I don't think there is anyone in the audience who personally or does not know of anyone that has been affected by COVID-19 pandemic. In the last few months of this year alone, we have seen more deaths than the entire year of 2020. And this has also underscored the gap between nations with means to acquire COVID-19 vaccines and the nations without means to acquire these vaccines. But this is not to say that vaccine hesitancy has not played its own detrimental effect on availability of these vaccines to the general public. And here I feel that we all have to play our part and continue to harp on our patients in general, our family members, our friends, that the vaccine is only our ticket out of this. Without belaboring the point, in terms of financial impact, the United States alone, with all the hospitals nationwide, are expected to lose $54 billion in net income this year. The cost of average patient is around $208,000, whereas patients in the United States with COVID-19 who have complexities during their hospitalization, the cost can be, it can average out to $317,000. So these are sobering numbers. In terms of the vaccine itself, worldwide, several different vaccines have been used, including vaccines from Russia, China, some from India. There's a vaccine that Pakistan has produced as well, but I'll focus on United States. In United States, we have used the mRNA technology to produce Moderna. There is the Pfizer from Europe, then Johnson and AstraZeneca. These have all been approved. Since the brunt of COVID-19 pandemic is associated with Delta variant, it is important to mention this newly released data from CDC just a few weeks ago that studied about 32,000 patients, individuals actually, who have received the vaccine, and it showed that COVID-19 Moderna vaccine was 95% effective against the Delta strain. It was the Pfizer vaccine was 80% effective, whereas J&J was 60%. However, the most important point is that the vaccine that you have access to, or the vaccine that your patients have access to, is the most perfect vaccine for them or for you. So just wanted to make sure we are clear on that. In terms of hematologic malignancies and COVID-19 outcomes, so Liang, in the earlier part of 2020, showed through his paper that patients with cancer are at a higher risk for invasive ventilation and death. The CFR was 7.6%. Sorry, I'm hiding it. Later, this was further polished up with another paper by Robilati. And here Robilati mentioned that it's not any cancer patient, but hematologic cancers that are at a higher risk for hospitalization and severe respiratory illness from COVID-19. This was further refined by Kuderer in Cancer Consortium cohort study that studied about 1,000 patients, and it showed that increasing age, 2 or more comorbidities, hematologic malignancies compared to solid tumors, and not just any malignancies. We're talking about active progressive cancers as opposed to cancers in remission. And we'll talk more about that in our CLL part of this presentation. And also patients who have poor performance status. They are the ones who are expected to have poor outcomes from COVID-19. Let's talk about immune checkpoint inhibitors and COVID-19. So immune checkpoints have been approved for a vast array of malignancies, both hematologic and solid malignancies. Here we will focus on Hodgkin's lymphoma. As you all know, both pembro and nivolumab has been approved and is used for the treatment of Hodgkin's lymphoma. Here we will discuss 4 different studies. The first 2 are retrospective reviews, one from Memorial Sloan Kettering, studying about 423 patients. And the second one was a Chinese multi-center retrospective review, studying about 105 patients. Both of them showed a higher association with adverse outcome with the use of immune therapy in patients who then developed COVID-19. Later, you had 2 other studies. One of them was, interestingly, retrospective review from the same group at Memorial Sloan Kettering, studying 69 patients. And then the last one is the international cohort study that studied 200 patients. And these 2 showed no association between the use of immune therapy in patients who later developed COVID-19 in terms of adverse outcomes. So what it really boils down to is that the studies that were done in the earlier part of the pandemic, in earlier part of 2020, seem to have a poor correlation in terms of immune therapy use and their outcomes with COVID-19 compared to patients that were treated later in pandemic. And I think that has to do with all these treatment modalities that some of the other presenters will definitely talk about. In terms of using mRNA vaccines in patients who are already on immune therapy, Weissengrain showed that there was no increase in adverse effect profiles in patients who were given vaccines in the setting of immune therapy for their cancers, except for muscle pain. In clinical practice, we know that myalgia is common, especially localized muscle pain at the site of injection, and these are treated symptomatically. So based on these studies, last time I checked, the NCCN guidelines do not prevent anyone from obtaining vaccines. Whether you're on immune therapy or cytotoxic chemotherapy, vaccines are recommended to be administered as soon as they become available. However, we expect an attenuated vaccine response in patients who have GVHD or being treated for one, who are on rituximab, BTK inhibitors, JAK inhibitors, have hematologic malignancies, and are immunosuppressed. So let's jump into CLL and COVID-19. So in terms of the efficacy of vaccine, this is a wonderful paper in Blood that just recently came out studying the efficacy of a Moderna vaccine in CLL patients, and it showed that the efficacy was much lower in patients receiving Moderna vaccine in CLL patients compared to the healthy control groups. And what it really boils down to is that the patients who have CLL in remission do much better with an efficacy of about 80% compared to treatment-naive CLL patients, whereas the efficacy in patients on active treatment is only 16%. These are management algorithms that you are very familiar with. To simplify this, you can divide it on the basis of age. Younger patients can benefit from FCR. However, BTK inhibitors, CD20, venetoclax remain the standard of care in most situations. This is also true of patients with CLL with deletion 17p and TP53 mutations. And since BTK inhibitors is such a common tool used in CLL, we'll focus on BTK inhibitors. In terms of the outcomes, it's really the disease burden that determines that. So in terms of COVID-19, the symptoms can be mild versus more severe, and then sometimes the symptoms may overlap with treatment-related pneumonitis or associated opportunistic infections. In terms of CLL, there are those you won't even treat, but then there are those who need active treatment, and then it becomes an intellectual discussion as to what treatment modality will be best for them. So let's discuss IVIG immunoglobulins in CLL patients. So in patients who don't have COVID-19 infections, the guidelines have not changed. So you will treat them based on NCCN if IgG is less than 500 or if they have recurrent sinopulmonary infections. However, in COVID-19 infections, there was this question about whether we should preemptively give them IVIG, and there is no specific indication for that. However, the use of anti-SARS-CoV-2 monoclonal antibody has just recently received emergency approval and is being used in hospitals throughout the United States. It is significantly reducing hospitalization, the duration of hospitalization, that is. And my hunch is that over the years, we will see survival benefit, hopefully, with this treatment modality. So BTK inhibitors. The first three cases discussed with positive studies. So this is a study that came out early, studying ibrutinib in patients with Waldenstrom's who then developed COVID-19. There are 6 patients in this case study. 5 of them were treated at a dose of 420 and had no major issues. 1 of them was at a dose of 140, went through a very difficult clinical course, was intubated at one time, had to be taken off ibrutinib, was started off on tocilizumab, desatted, and then was put on mechanical ventilator. But on day 11, this patient was put back on ibrutinib 420 milligrams with rapid improvement in oxygenation and was then discharged. So this was a positive study. Then there is another positive preliminary clinical outcomes trial using acalabrutinib in severe COVID-19 infection patients. And it showed an improvement in both CRP, IL-6, lymphopenia, gas exchange, and all the other parameters set forth by the researchers as shown here. So this was also a positive study. Here is another positive study by Jones. It's a joint study by Eric studying BTK inhibitors in COVID-19 patients. Again, showed hospitalizations were much less frequent for patients on BTK inhibitors. Here we have a negative study in COVID-19 patients with CLL. Basically, this study suggested that there was no survival difference in patients who were initiated on BTK inhibitors during COVID-19 for CLL management and of course COVID-19 management, or who were resumed on their BTK inhibitors. Here is a graph here showing no difference in overall survival. Here is another phase 2 negative trial, the Calabi and Calabi US. Collectively they had about 200 patients who were treated again with acalabrutinib and showed no major difference in efficacy versus the best supportive care. So my thoughts. So this can be construed as an expert opinion, not necessarily NCCN mandated guideline. So in the United States, most of us will not initiate patients with COVID-19 on BTK inhibitors if they don't have CLL. If patients do have CLL and were never treated for their CLL and then come in with COVID-19, we will still not initiate BTK inhibitors. However, patients who are stable on BTK inhibitors and then develop CLL and are hospitalized, this is an area of controversy. It's a gray area. My predilection is that I'll continue them on BTK inhibitors. Of course, this is a discussion that you will have with the patient as well. All right, last but not least, tocilizumab and COVID-19. So tocilizumab is used in a whole host of hematologic conditions, especially those that cause cytokine release syndrome with BiTE therapy for multiple myeloma, ALL, etc., with CAR T-cell, and also in COVID-19 hospitalized patients who have worsening oxygen requirements. It's also used in TAFRO, and I was lucky enough to be the lead fellow who discovered the third case of TAFRO in the United States in 2017. And it was the first case of TAFRO in an individual of African-American descent. Tocilizumab, as you know, is an IL-6 blocker, which plays an important role in CRS. So we'll talk about just one review of about 25 different publications including 10,000, more than 10,000 patients. And to summarize, tocilizumab toci treatment was associated with a low risk of mortality and mechanical ventilation requirements among COVID-19 patients, especially among critically ill patients. So yes, we will use this or continue. So thank you so much. It was a wonderful experience, and I hope that you will contact me if I can help any of you with anything. This is some of my infusion nurses here at the Cancer Center, and we are very appreciative of the opportunity. Thank you so much and have a blessed day.
Thank you very much, Dr. Khurram Bilal Tariq, for an excellent presentation. And thank you all for joining for question and answer session. So obviously we are running a little bit late, so we have 15 minutes of question and answer. So although all presentations were thought-provoking and I have lots of questions, but let me start with the participant question. This is for Dr. Ehsan Waqar Khan. The question is that some centers use plasma exchange and convalescent plasma therapy in ICU population. What's your experience about these intervention at Shaukat Khanum Hospital? And I will also request Dr. Mohammad Raza to answer this question as well. So let us start with Dr. Ehsan Waqar first.
Thanks very much. Can you hear me?
Yes, I can.
Okay. So as I alluded to in my presentation, that when we started treating this disease, there was very little that we knew about it. And something that we decided on our institutional level, that we will not start off by treating with plasma exchange and convalescent plasma. So this was something that we decided fairly early on, because we thought that the evidence that exists is not robust enough for us to try this therapy. So in our experience, we didn't use it.
Okay, so Dr. Mohammad Raza, what is your take on this question?
So thank you. So one of my worries as a virologist is that if you are giving antibodies, you are just driving the mutations within the virus. So we've got other examples of various other viral actions where you just simply promote the virus to just change in a way where, even though you may have antibodies in very high concentrations, the area where these particular antibodies bind, it just simply changes. Hepatitis B is a good example. So unless there is robust data on its efficacy, then I would just stay away from it. And I know in the context of at least our stem cell transplant center here, immunoglobulins are thought to be a solution, the antiviral or anti-infection effect. But that's not always true. So I personally wouldn't recommend it.
Sure. And our next question is that, hematological malignancies, as you presented, that some patients have suboptimal response to vaccine. And they obviously are at risk of getting COVID-19 while they're undergoing anti-cancer treatment. Are there any clinical trials ongoing for prophylaxis for COVID-19? Are there any antiviral that you are being considered or being tested for as a prophylaxis?
Yeah, I think that there was there going on, which I'm not privy to the details of, and I'm sure, we learn sometimes from the media rather than just the right scientific channels. And there are, if you think about it, any drug which you use for treatment purposes could potentially be used for prophylaxis purposes. Now, as a concept, it all makes sense, and there are trials going on where you are trying to extract data which shows the beneficial effect. But at the moment, at a practical level, there's nothing which exists. And of course, one of the other things is that what you have to remember is that do no harm is the policy. So unless I'm convinced as a virologist at a professional level, that there is definitely those benefits. And to me, it's about finding the true risk factors which lead to severe infections and increase in mortality. And if we can sort of as a global healthcare community can just pin those down, then you risk assess and then define which group should really require prophylaxis, not just everybody. But you're right, the optimal responses, again, one of the problems there is these are the B cell responses, which is in a way the proxy to your T cell responses, because T cell function diagnostic tests are not readily available, and unless you know the T cell function. But if you give somebody a T cell depleting therapy, clearly they're at risk.
Sure, thank you. Professor Syed Hussain, obviously you talked about increased risk of COVID-19 in cancer patient, and also you talked about cancer survival obviously reduced because of the impact of COVID-19 pandemic, and quite brilliantly talked about priority levels and COVID-free pathways. And Professor McEnkeen, you kindly discussed about this model of care, obviously to reduce the risk of getting infections. Obviously, it was very inspiring, particularly this community level delivery of low-risk systemic anti-cancer treatments. My question is to Professor McEnkeen, that this community level, obviously, it also will be supervised by the consultants in the cancer center, but is it the specialist nurses will be obviously looking after patients who are on TKIs or who are getting, bisphosphonates treatment, or in the GP setting, or there will be a new community level provision of services?
No, we wouldn't plan to add a new level of service. What we plan to do is integrate with current service. I mean, the concern here is around, we've had several concerns, and these things predate COVID. The first of which largely is the explosion in requirement for care. The second thing is the reducing level of toxicity of care, despite the fact and definable toxicities. So that is an enormous impact in terms of our burden of requirement for delivery of care. The third thing is that obviously with the COVID-19 pandemic, and this will be repeated. If you look at what's happened, we've had 3 waves come through. There is no reason with globalization that we won't be dealing with pandemic or pandemic equivalents, perhaps epidemic equivalents of not just this, but other viruses and other agents that I think down the road we need to future-proof for. And the final thing that we had here that others didn't have is we had a major ransomware attack. So we effectively had a viral attack of a totally different type on our IT structures. But our healthcare systems need to be robust enough to deliver cancer care within that clinical context. And that's going to be an ongoing issue for all of us. If you look at the data that most people have presented here, the viral data, the ICU data, and the therapeutics data, largely it has been about continuing to give our current standard of care the context of these problems. And one of the best ways, in my opinion, to do that is to disperse the way we give care. The idea that we drag every patient into a cancer center to administer what is low toxicity agents that don't require the level of support that a major center gives doesn't make any sense in the modern world and in terms of modern therapeutics. I would describe this analogous to diabetic care, which used to be brought into major diabetic centers. That's now dispersed throughout all of our GP services. So there is real opportunity with structured governance to radically impact the way these things can cause problems, but more importantly, can radically improve the patient's experience. Because the patient's experience of having to come in for blood tests once or twice, a week, or as it would be with hematologic malignancies, or more frequently, in modern medicine doesn't make any sense.
Sure, thank you. I think same question to Professor Syed Hussain as well. That obviously you talked about priority level and COVID-free pathways. Are you considering delivering low-risk systemic anti-cancer therapy in the community, or are you practicing this?
Thanks, Rizwan. Really heard Professor McEnkeen's talk with great interest. I think it was a really good model what he showed. I think what my data was showing and what others have proven actually that I think it is the Cancer itself, which is a much bigger concern than COVID-19, what we learned from studies, the concern was that there were delays in treatment pathways, and the delays were understandably in the first lockdown. Nobody knew what is the right thing to do. And those were the priorities I showed you. Those were the priorities given to us by our guideline authorities. And they were telling us advanced metastatic bladder cancer or prostate cancer, kidney cancer, they were level 5 or 6 who may not be treated. And that's where the background of my study is, which was based in between April to June, sort of patients who came in for those 3 months. And some of the data that I showed you, which showed that actually the risk of screening activity, referral pathways, all went down. And the impact of that we are seeing now. We are seeing a stage migration in advanced cancer. We are seeing more advanced cancer where we can do palliative systemic treatment than curative treatment. And that is something we need to all globally work together in improving the outcome for. In terms of that question, definitely this is a model that has been used for some time now. And I think it is being looked at in more detail now because, I think there were huge challenges, but the opportunities were to see, for example, oral treatments for prostate cancer are being delivered by home care delivery. So you can have some of those discussions on the phone or bring the patient with the bloods and then send, you don't have to see them very regularly. But similarly, when you're giving systemic chemotherapy or immune checkpoint inhibitors, where initially we had no data whether it is safe to give or not, but now we've got good amount of data, including the work that I showed, my own experience from Sheffield and other centers in the UK and abroad, that it is safe to give both systemic chemotherapy and immune checkpoint inhibitors and in combinations as well. So I think there are different new models to look at to help improve the optimization of care delivery without compromising the outcomes. And I think one of the key things which is now coming out after almost 2 years of COVID-19 pandemic going through and multiple lockdowns and multiple waves that came through, that actually we really need to be very carefully making sure that the pathways that we have delivered over the years by trying to improve treatments and bringing treatments earlier to patients, we should really focus on those as well. We should not delay treatments. And one of the slides which I showed that some of these cancers can have a significant impact on outcome and survival if you're delaying treatments.
Great, thank you. I just have a question for Dr. Mohammad Raza. Obviously, you have seen that in Pakistan, obviously COVID had affected, and there was mortality of around 27 or 28,000 so far. But as compared to the other ethnic groups, or as compared to the other people in the world, obviously the mortality rate was quite less. What do you think are the factors? Is it only because of a smart lockdown, or is it the Pakistani population were more, immune, naturally immune to these viruses?
So I think let's take the context first. So when we first started with the pandemic, the mortality rates which were quoted were quite high. And the data emerging from China was that people were dying on roads and the mortality was so high that the whole world needs to really just worry about it. But one of the things which was missing was the denominator. So the question is all about the data in terms of how many people are actually getting infected. And we do have a very different view. We see patients who typically staff members, healthcare workers who get the infection and they don't get any complications. So the vast majority of the infection actually just settle down spontaneously. So by looking at hospitalized patients, you're automatically by default, you're biased because these are the people who will present and you will capture all that data. So the more you test, the more you dilute down the mortality. So the figure you quoted of 28,000, obviously I don't know what does that translate into the proportion of the population and the proportion of the positive cases which went on to develop this particular one. And we all know the risk factors have been defined as, and we've certainly seen higher mortality in some of the healthcare workers in ethnic minorities and people with diabetes, etc., where you'd see them more often in this particular background. But otherwise, you're right. The infection seems to have not affected the that part of the subcontinent, Pakistan. And we know this from some of the other infections, that the more you mix up, the more you live in cramped spaces, the more the chances of getting infected without even knowing. So there is a proportion of these patients where you don't even develop symptoms, post-symptomatic, for instance. So I think the dynamics are much more complicated than what we know. And I don't have a clear answer in my head as to what's happened, because I'm sure the public health experts have looked at it. But what I would like to say is that I'm not entirely convinced that the data sets we collect are truly representative of what we think is the problem. And I'm sure in 2 years' time, 3 years' time, we'll be talking differently.
Sure. So we have a minute left. So I have just last question for Dr. Ahsan Waqar Khan, that in your experience, patients with COVID-19 pneumonia, patients who recovered from a ventilator or who were successfully weaned off from the ventilator, did they have any particular features, or could you predict that which patients are going to recover and which patients are not? Were there any particular features that you noticed in your experience?
I don't think I can particularly say about a feature that would lead us and that would give us a clue that this patient is going to do better than the other. All of our patients, all of our subset of patients develop secondary infections. And if I could pinpoint something, that would be that those who recovered from these infections, those are the ones who actually got extubated, and we were successfully able to wean them off. And our data suggests that we had all of these patients had infections coming from different parts of the body, different anatomy, from the blood and from the lungs, and they were multi-resistant organisms. In a week or so, once we started treating them, if they were responding, only those patients we were able to extubate. And it is also interesting, worth mentioning here, that we were able to extubate them, but they went on to non-invasive ventilation pretty much straight away. That is again an institutional idea that this is what we will do. And none of them were extubated before 2 weeks.
Great, thank you. Thank you very much, Professor McEnkeen, Professor Syed Hussain, Dr. Muhammad Raza, and Dr. Ahsan Waqar for participating and for an excellent presentation. Thank you again, and stay safe, and see you hopefully face to face next year in our 21st symposium. Thank you all. All the best.
Thank you very much.
Thank you.